know me, I'm Director of HR and Organisational Development here in the hospital. Absolute privilege to chair Report Out. Looks like we've got two fabulous colleagues, presentations, and then we'll do some questions and answers at the end. So I'm going to hand over to John in theatres and anaesthesia. Please, John.
Thanks very much, Jenny. So my name's John Summers. At the time of writing this presentation, I was a ST7 in anaesthetics at the Trust, but I completed my training last week, so I'm looking forward to starting as a locum consultant at some point very soon. The title of my project is Developing the West Yorkshire Transfer Checklist for Isolated Brain Injury Patients, with the aim of improving the quality of these time-critical neurotransfers, so transfers via ambulance into LTHT for life-saving neurosurgical intervention by developing this checklist. So next slide, please. So a little bit of background. So Leeds is, as I'm sure you're aware, the tertiary neurosurgical centre in West Yorkshire. Patients usually present at their district general hospitals, their local hospitals, with the primary brain injury. For example, most commonly a bleed on the brain. If it's severe enough, they're often stabilised, they're anaesthetised, intubated, ventilated, sedated and transferred urgently to the LGI for some form of neurosurgical life-saving intervention. The transferring team is usually made up of an airway trained doctor, such as an anaesthetic resident, a nurse and the paramedic team as well. It's quite a commonly done transfer. There's on average 1 per week into neuroacute theatres for life-saving intervention. And they're quite a high-risk transfer. These patients are very unstable, particularly the more extreme cases. They're very sick. And there's a risk of developing a secondary brain injury and ultimately leading to a poor patient outcome if basic things aren't done well. So that's things like blood pressure management, attention to carbon dioxide and oxygen levels, that sort of thing. Empowering the transfer team is key, so giving them the knowledge, the skills and the resources to ultimately safely do these transfers is crucial to improve patient outcome. When I started this project, there was a lack of available guidance in West Yorkshire for these cases, and this is a regional-wide project, so it involves all the hospitals in West Yorkshire, multiple trusts and emergency departments where often these patients initially present. When we're thinking about the 7 commitments of LTHT, so this project links in quite nicely to those. I think, it is aimed at improving patient care and quality of the transfer. So if they arrive in a better physiological state, the chance of developing a secondary brain injury and ultimately poorer patient outcome, high risk of mortality and morbidity is hopefully lower. And it makes use of digital resources such as the checklist, not only being available on the existing transfer paperwork, but also on people's smartphones, where there's useful things like QR codes that link to more information should they need it. And it also empowers the team involved in the transfer. The checklist gives them the confidence and knowledge to safely carry out these transfers. So next slide, please. This is a brief timeline of the project. So it started back in May last year, where we realised there was a problem, that these transfers could be done much better. So we started by initially carrying out a survey to all resident anaesthetists in the region, just asking about their current level of understanding and confidence in managing these patients on the transfer itself. From July through March, I developed the transfer checklist, went through multiple iterations, and various teams such as pharmacy, neurosurgeons, critical care consultants, anaesthetists, and refined the document with close communication with medical illustration. And this is the document you can see on the right hand side of the screen. We don't have time to go into it in a lot of detail, but essentially it's a transfer checklist for brain injured patients. So it's got lots of medical information on there, but also key parts of communication such as mobile phone numbers, contact numbers, and a QR code to link to further useful information should the team need it. So this went live in March. From March until July, I gathered data of transfers coming in after checklist implementation, and then compared that to a retrospective audit of transfer quality. So this is transfers that were done in the year before the checklist was went live, and focusing from a LIM metric side of things on the quality metric there, the quality of the transfers. So next slide, please. In terms of the Leeds improvement method tools used in the project, so given it was a regional wide project, which ultimately aims to improve the care for patients coming into care under LTHT, it was tricky to do things like the Gemba walks and spaghetti diagrams in such a complex system. But what I did find really useful was developing a process flow map. This helped me to visualize the entire process and the key action points and decision-making steps that were required along the way. It highlighted to me that communication is key in a complex system such as this, and anything to make the life of the transferring team easier would be helpful, such as a checklist which gives medical guidance and advice on medication doses, for example. So next slide, please. So how did I engage the team? So I ensured that the checklist was easily available. It's being printed on the existing transfer paperwork that all transferring teams should use anyway, so it doesn't lead to duplication of paperwork. It should be hopefully available on most smartphones of the transferring resident doctor, resident anaesthetist or intensive care doctor. So it was very accessible. I feel I also listened to the key stakeholders by use of the survey and also gaining regular feedback from those using it in real time. This enabled me to troubleshoot key issues as they came up, and also I feel like it involved the stakeholders in the development of the transfer form. Next slide, please. In terms of the outcome, so on this slide is the data from the retrospective audit pre-checklist implementation on the left-hand side, and then post-checklist on the right. It was pleasing to see that the oxygenation remained at 100% compliance, so it was within range. The areas highlighted in the red box are the three parts that I feel determine how well blood pressure is managed en route. So the first one is whether the blood pressure was in target for the pathology in question. Now, there's lots of different pathologies that encompass the broad term of traumatic brain injury, and they each have slightly different blood pressure targets. So actually, it's quite important to make sure the blood pressure is nice and steady, and that showed an improvement, which was pleasing to see. Also, the way the blood pressure was monitored showed an improvement, and whether a vasopressor infusion was used. So that's just medication to help stabilize the blood pressure, particularly if it's low. The management of carbon dioxide, which can impact on developing secondary brain injury, was better as well. So next slide, please. So what went well? So I collaborated with a lot of people during this project. It's been going on sort of 18 months more or less, and lots of different people have been involved that I've been working with. So anaesthetists, intensivists, emergency medicine doctors, emergency medicine departments, the West Yorkshire Critical Care Network and Transfer Forum, medical illustration to help with designing the form and reformatting it, and the trust and also network pharmacists as well played a crucial role. I really feel like I understood the key issues in this area due to personal experience, having transferred lots of these patients, but also being on the receiving end in neuroacute theatres at the LGI. I really feel like I empowered the transferring team and gave them the resources and confidence to try and improve the quality of their transfers they do. And ultimately, I feel like I've made a regional change, which will hopefully continue to impact in a positive way the care of patients that ultimately end up under Leeds teaching hospitals. Next slide, please. So what would I do differently? If I were to do this project again, I definitely would try and recruit more people from the start to share the workload. although there was lots of people involved, a lot of the work was just me and driven by me. So actually having a few more people to help with that data collection and things would have been really useful. And in an ideal world, I would have got data on transfer quality before implementing the checklist, but there was limited time to do this because the priority was just to get the checklist up and running to improve things as quickly as we could. Key learning from the projects: persistence is key, attention to detail, optics of the project was really important, so awareness of this being a thing, and otherwise people aren't going to use it. And also empowering the transfer team was crucial. And actually, this is a direct quote from some feedback I got from one of the transferring doctors, who said, "It was my first time taking a patient in an ambulance. I felt I did a good job and undertook a systematic approach, and I found the checklist very helpful." So that was really pleasing to see. Regarding next steps, so the neurotransfers are now part of the West Yorkshire Critical Care Network transfer course, which will hopefully enable sustainable education on this topic. And the checklist is printed on the new batch of the transfer paperwork that all teams should use. So that should ensure longevity of the checklist, and not just another piece of paperwork to take on the transfer. So thank you very much for listening.
Wow. So I will open it up for questions at the end, standard work, but I've got to say, spotting the need for that, John, that was awesome. So I'll hand over to Gemma next, and then we'll circle back round for some comments and questions later.
Hi there. So my project was basically just to reorganise the layout of Ward L28. So I don't know if so my name's Gemma. I'm the band 7 on L28. I don't know if any of you know the layout of L28, but L28 is down in the old site of the LGI, so it's not an ideal location. It's not an ideal layout of the ward. Next slide, please. So you can see from this slide, this is the initial layout. Down at the bottom, where number 1 and 2 is, we've got just basically a junk room and a drug room, and then we've got the sluice down in number 3. 4 was a bit of a linen patient care cupboard. 5 was just another storeroom. 6 was where stationery was stored. 7 was the main supply room. So you can see down in the bottom right hand corner, you can barely get in that room. You can't swing a cat, let alone find what you need. So my project basically was to reorganize, because a lot of time was wasted kind of daily going from one room to another. It's very spaced out. So it links in with the Trust 7 Cs of being sustainable, financial, resources, compassion and team. So I only took over the ward in December last year, and sort of just watching people sort of in the day-to-day tasks, I realised a lot of time was wasted. So next slide, please. So I looked at how we could work better to cut down performing basic care needs. So I used some timed observations, and I did a Gemba walk with staff, and we looked at how things could better be positioned. So just basic tasks like getting patients ready for a wash, from leaving a bay to gathering everything needed to wash a patient and returning back to the bay. It was wasting sort of 45 minutes just walking from one area of the ward to another. And that's just bearing in mind one patient's wash, you know, and obviously you need to change people more often than once in a shift. And then time to gather things to do a wound dressing. It was taking at least 1 minute 35 just to get stuff to do a basic dressing. You had to go to 4 different areas of the ward to get everything you needed. Next slide, please. So I looked at reconfiguration of the storerooms, and then we repeated doing some timed observations. So you can see there, just basic washes, 20 patients once per shift. We saved 35 minutes per shift, just reconfiguring. And items needed to do a wound dressing, we saved on average 6 minutes 45. So it's quite a simple change made, but quite a lot of time. Next slide, please. So the reconfiguration of the ward, you can see we've moved the main storerooms down into what was just a junk room. It's all colour coordinated, labelled, organised, tidy. And what was the original storeroom down in number 7, bottom right hand corner, you can now see we've got patient equipment in there. So previously that was all in the day room, and that is where the therapists also do all their therapy. So when the physios were needing to do any therapy, they had to move all them chairs somewhere just to create a bit of room, which again is more time wasted. I didn't look at the times kind of there, but you could just see it's a better layout, better organised. The storeroom's literally bang opposite the nurses station, so you can get what you need, and the patient care cupboard is all in one place. So a lot of that stuff previously was in the sluice as well, which is not ideal from an infection control point of view either. So it's all in one place, easy accessible. Next slide, please. So what went well, you can see just from wound dressing, cost saving time is £1.78 approximately per day. Completes washes time, just in time, it's £6.68 approximately per day saved. That's nearly £60 per week just on time. It releases the staff to do other tasks. It doesn't include cost saving of physio time, like I say, them moving all the equipment to get what they need. The ward's tidier, it's more efficient, and it also reduces the amount of excess stock and over ordering and out of date stock, because you can see what you've got, and ordering of stock from the stock from the supplies team takes a lot less time, because you can see what you've got. You don't need to go searching. Next slide, please. So initially I felt like the project went really well. We engaged the team. I looked at kind of how the ward could work better. Staff are obviously a little bit frustrated, because I think, you know, whenever you move something, you can't find what it is. So initially we were really frustrated. They couldn't find what they needed, but obviously over time it's got better, and it's actually working with the stores team. We've actually got the same colour coordination and order as all the other neuro wards. So if you've got staff moving from one department to another, it saves time then. You know, every storeroom is pretty much similar now, so you know where you go in a storeroom to get what you need. So massive time and frustration of staff when they're moving from one area to another. So key learning is basically something so simple can make such an improvement, and we're looking at going forward doing more improvement projects on L28, which will help patient care, reduce harms and reduce length of stay in hospital. So quite a simple project, and hopefully, you know, quite a big difference. Thank you.
Wow, Gemma. Well, first of all, thank you for joining us from home. And secondly, just your time observations, those before and after pictures. And particularly, I love that you've helped those that need to move between wards. We know we have to do that in order to make sure that we've got our capacity aligned to where we need it most. But we also know that our staff don't like those moves. So the more that we can help people feel more comfortable in moving between those clinical areas, I think that was an absolute real nugget. Thank you. So very inspiring. Let me open this up, please, to colleagues on the report out for some questions, some comments, some observations. There's one in the chat for you, John. Let me open it up. Paul?
Yeah, I mean, 2 fantastic report outs. Thank you both. John, I was just wondering, because you talk about printing out the checklist. Do we do that, or is that the trust that it's coming from? And then how have you had to engage with them to get them to change stuff?
So that's all managed by the West Yorkshire Critical Care Network,
right? Okay.
who I contacted from back in, when was it, May, when we first came up with an idea to make this checklist. I think it helped because I was working in a different trust at the time, where the current lead for the transfer network was based and working as a consultant anaesthetist. So I spoke to him about it. He thought it was a great idea, and said that the network would support that support that change. So so it's a big A3 document that they use to essentially record patient observations en route and a load of other stuff on there, and it's going to get printed on the back of that, which is great because it doesn't, you know, duplicate paperwork. And in the survey I did with the residents right at the beginning, one of their main concerns was that this was going to be another you know, A4 piece of paper that they'd have to try and track down and risk losing on the transfer. So actually that was a key point involving them early.
Right, thanks, John. And actually, just while I'm on, could I just comment on Gemma as well? I think you're underestimating the impact that having a tidy work environment has on people's stress. And I know we can't kind of quantify it, and we always should in these KPO things, but just things being organised in a sense of order just takes kind of people's cognitive load down a level. And when people are stressed and busy, that has a huge impact, I think, on staff and then subsequently on patients. So it's very hard to measure that, but I think that was a fantastic kind of delivery out of what you did as well. So thank you.
Yeah, I agree with that. I really agree with that.
My stress levels certainly went down with the organising. I don't like clutter.
Oh.
Anybody else want to come in with any questions or comments? Andrew?
It was really just a comment on Gemma's initially. So I did a similar when I did my report out, and I did a 5S on one of our anticoagulation service, and it's so cathartic. But looking at those flows of materials and medicines, and so it's, you know, cost savings are great, aren't they? But they're not always what the staff want. They want the time back, and I think being able to give them 35 minutes back on a very busy ward is probably really invaluable. So I think I love a 5S, and doing those sweeps and improvements, because you might say they're small, but they're not. They're really beneficial, I think, and just organisational, you know, just giving people time back is the best thing sometimes these days. And John's, I thought John's was amazing as well. We've got a similar project in oncology. We have a bypass service as well for some of our patients that come in via for sickle cell when they're in a crisis. So I've just made a few notes to speak to our team about that. So it was really interesting. Thank you.
Brilliant, lovely. Thank you, Andrea. I love your comment about I love a 5F. It's such a visual change, isn't it? It just and as Paul was saying, I think, Gemma, you've definitely understated the impact that will have had. John, I was intrigued as well. I loved that you started with asking your clinical colleagues sort of their experience, their confidence level, their knowledge. What were the big things that came out of that sort of helped you with the checklist? Was there a theme? Was there just lots of?
Yeah, so there was quite a few themes. So there are some national guidelines for transferring brain injured patients that the Association of Anaesthetists released in 2019. And one of the main themes was that a lot of people just weren't aware of those,
right,
or they hadn't read them. And the blood pressure targets are lifted from that document. So that was one of the themes. The other one was that the handovers could be better. And from this project, it's, you know, we haven't started work on it yet, but it's a definite room for improvement further from here. So the handover from the receiving team coming into from the transferring team coming into the receiving team already in theatre needs to be better as well. So I'm currently thinking about how to improve that. But, you know, I think there's 52 people did the survey, and actually their confidence in the medications could have been a lot better, which is why we made a specific drug formulary, which is on the QR link to the network website. So, but yeah, that was a really valuable piece of work.
Yeah, fabulous. And I think somebody put in the chat, I've not got it open now, but I think somebody put in the chat, I mean, gosh, just such an important thing to set a standard for at such a crucial point in somebody's care pathway. So just phenomenal work. Well, inspiring as always. Just it keeps talking to just how powerful our method is. John, I love that you took from the method the bits that were applicable and you realised the bits that you couldn't. So I really like that we're getting confident with it now to be able to say I'm going to work with the bits that I need and are going to help me. And I'm probably I love a 5S, Andrea. I agree. I think that's a great statement from today. And I also loved Natasha's point about without standards, there can't be any improvement. So what an inspiring report out. Really, really lovely way to spend a Friday lunchtime. And unless there is any other questions or comments, I'll give you 5 minutes back, probably before your next meeting. But congratulations, folks, on your work. Really, really well done.
Thank you.
Thanks
very
everyone.
much.
Yeah.